This is Dr. D here. I apologize for the lateness of this presentation. As some of you know, my husband's been very ill. He is undergoing evaluation for lung transplant and was in ICU Thursday, got out last night on BiPAP. He's stable now at home, but it has been challenging. So I appreciate your patience, and I'm sorry. The last couple of weeks have been kind of tough, so I've gotten a little behind, which I hate to do. Okay, so let's go ahead and start from the beginning at this, for this exam review for health promotion and digital health and our role as a nurse practitioner. I perform these reviews at a concept level. It's not an item by item answer key. So the goal here is to be able to reproduce the reasoning behind the answers, because the same constructs are going to appear in different clinical wrappers on future exams and on your certification exam. It's an odd question here that we have 87 questions on this test. I did not create this course, so I can't answer as to why there are 87 questions on this test. But there are, so let's just take it as it is and move forward. All right, so if you look at this slide here, it's a map of the exam's underlying blueprint. It refers to 8 domains, and all 87 items on this exam are related to these 8 domains. They're weighted unevenly. Digital health, equity and behavior change, together are roughly about half of the questions. Digital health definitions and boundaries, so telehealth versus telemedicine. The 3 delivery modalities, mHealth tools, wearables, and AI clinician support. Digital divide and equity, so who lacks access, why, and what the nurse practitioner does about it, including the barriers and how to document them. Behavior change, the trans-theoretical stages, motivational interviewing techniques, which I think is incredibly valuable. I use it in practice all the time. The 5 A's counseling framework. So this is where some of the students miss questions that I found. Documentation, what belongs in the SOAP notes section, and how to recognize a red flag that exceeds a wellness visit, and how to rank assessments and write measurable plans. Lifestyle medicine, evidence-based practice, diet patterns, exercise prescription for comorbidity, alcohol reduction, deprescribing, provider wellness. Then is how do we take care of ourselves? We have such a huge burnout level of burnout. Moral distress, general adaptation syndrome, coping patterns, and organizational culture can be a barrier. Ethics and law, including informed consent, veracity, scope of practice, and HIPAA. In population health, we're looking at the social determinants, equity, advocacy, and the prevention across the lifespan. So on this exam, you're going to be rewarded if you recognize which domain a vignette belongs to. Once you name the domain, the distractors usually collapse. So think about that when you are reading the question. All right. Telemedicine is a subcategory of telehealth. Telehealth is the larger umbrella. So telehealth includes everything delivered at a distance in service of health clinical visits, but also patient education and providing education, administrative functions, remote patient monitoring, and public health outreach. Telemedicine is narrower and specifically clinical. Direct patient care delivered remotely by a clinician. So this is the patient that has a sore throat and wants to be tested, or not tested, but treated online. Diagnosis, treatment management, medications, The two distractors worth naming: telehealth is a type of telemedicine used for emergency services. Inverts the hierarchy, and telemedicine is broader than telehealth. It inverts it outright. So any option that makes telemedicine the umbrella is wrong. So when you're looking at telehealth improving health education, one of the methods to do so is delivering asynchronous educational videos through a patient portal, a non-clinical education-focused use that only makes sense under the broader telehealth definition. Restricting education to written materials or in-office group sessions removes that telehealth element entirely. Automated prescription refills are an administrative function, not education. So telehealth is the health system at a distance. Telemedicine is the visit at a distance. So being able to differentiate the two is an important key in this exam. All right. So let's look at these matching the modality to the patient. Synchronous, asynchronous, and mHealth, which includes mobile apps and smartphone apps, things like that. So we want to match the modality to the patient constraints and work through all three of these categories and apply the rule that synchronous means real-time, two-way interaction through a live video, live phone triage, group therapy at a local hospital, and in-person outreach. Both reintroduce the transportation barrier, and text-only messaging is insufficient for follow-up requiring assessment. Asynchronous means store and forward with no live contact. This is portal messaging, uploaded readings, e-consults, secure images, education videos. So let's take an example of a patient with high blood pressure. They upload their blood pressure weekly, and then they get a response. This is an asynchronous case. Now let's look at mHealth, real-time Bluetooth syncing. So mHealth is mobile health, smartphone apps connected to devices supporting self-management. So you can have a smartphone that tracks your blood sugar and transmits data to the provider. The synthesizing rule chose the lowest bandwidth modality that still meets the clinical need. So high bandwidth options fail patients with the fewest resources. So think about that when you're looking at your exam questions. mHealth, wearables and what they actually do. Now, wearables and mHealth, they do deliver real-time data sharing and self-monitoring. That's true. But they don't replace in-person physical exams. They don't generate automated prescriptions. They don't eliminate the need for provider follow-up, and they don't restrict care to patients with high digital literacy. Health apps and wearables aren't limited to fitness and exercise goals. Continuous glucose monitors, blood pressure cuffs, medication reminder systems, and symptom trackers are all standard. So when you're thinking of getting ready to study for the exam, think about this. Whenever an option says a technology eliminates or replaces the clinician, it's wrong. The technology expands the reach of the provider and helps to retain that clinical relationship. AI in the clinical setting. Now, AI in clinical decision support, we want to reduce them to one core function and three workflow implications. So AI recognizes patterns in data to predict clinical risk. Let's look at metabolic syndrome. The system reads the electronic health information data and identifies at-risk patients. Distractors described document upload, meeting scheduling, and imitating human empathy. All either clerical functions or a category area about what AI does. So when you're looking at the exam, I want you to think about predictive analytics for disease risk. And scheduling and manual documentation are administrative, and providing physical therapy is a hands-on service that AI cannot deliver. Okay. AI enhances promotion by offering personalized data-informed recommendations, but it doesn't replace the patient-provider relationship. Delay or intervention or control patient behavior. There can be two distractors. There can be ethical violations dressed as capabilities. When the tool flags a patient as high risk, the person-centered next step is to send a lifestyle screening questionnaire through the patient portal. Mailing a printed brochure is passive and untargeted. Waiting for the annual visit wastes the alert. Auto-referring to endocrinology without follow-up removes the patient from the decision, so that's no good either. Paper charting, front desk voice messages, annual paper surveys all break the loop between the flag and the action. The consolidating principle is that AI generates the signal, the workflow and the clinician generate the care. An alert with no defined downstream action is not decision support. So there definitely needs to be a process in place that, you cannot create a red flag algorithm and then not have a pipeline to treatment. All right, so let's look at this, the digital divide, barriers. And you'll see this theme repeated a lot on this exam. And two skills are being tested: naming the barrier accurately and refusing the distractors that solve access by removing the patient. So a barrier to telehealth can be access to or digital literacy, actually, combined with internet access gaps. Not necessarily a lack of provider education, not overuse of fax machines, not too many in-person visits. Patients can worry about technology use and data privacy, and older adults without smartphones or high-speed internet, this is a huge barrier. The population most likely to experience digital divide are elderly patients in public housing without digital literacy or internet access. So compare the distractors. Urban college students with smartwatches, working professionals with employer coverage, pediatric asthma patients supported by a school nurse. They all have either the devices, the connectivity, or the human support. Barriers are layered and compounding, and the exam wants you to see that stack. Language, income, transportation, inflexible work schedules, device ownership, and bandwidth. A patient can clear 4 of these and still be excluded by the 5th. Now you'll find in non-English speaking patients, they have a pattern of missed telehealth visits. Low-income patients, this is a signal. It's a design failure of the delivery model, not the patient. Non-compliance, framing it as non-compliance is incorrect. The distractor pattern in the call-out is worth memorizing. So any answer that fixes access by excluding people, limiting telehealth to English speakers, dropping older adults from the program, or focusing resources on in-person visits only, it's going to be wrong. All right, so let's talk a little bit about the exam and how it's set up. These tests use vignettes a lot and wants you to read these vignettes and decide what the nurse practitioner should do about the divide. We have 4 interventions here. Categories cover everything here. Simplified, the tool offers streamlined low complexity platforms rather than requiring patients to buy new equipment. You don't want to advise the patient that they need to upgrade to a tablet before using telehealth. That defeats the purpose. And methods to help patients overcome this technophobia in older adults. Training sessions can help a lot, and trying to use tools that are simple. If you have a patient who's presenting that's hypertensive and mobility issues, one-on-one telehealth orientation using these simplified platforms can be incredibly helpful and add a human bridge. Now, low-income patients that don't have smartphones or internet can be referred to community health worker or digital navigator. There are a lot of systems out there that social workers typically know that we may not know, that can provide these services at no or low cost. Now, launching a patient navigator program providing multilingual tech support is wonderful. Now, but not always possible, right? I mean, this is an added expense to the practice. In a small practice, this is maybe something that isn't achievable. When the barrier is structural, the intervention is a person, not an app. So don't assume the caregiver. Any type of family involvement involves the patient consent. Adult children cannot conduct visits on the patient's behalf by default, and I see this happen sometimes. I get patients who come in with their children who speak English. They may not speak English, and they want to act as interpreters, and we can't have that. We have to use a approved interpretation or interpreter service. Okay. Okay. So soap placement is a skill. It's a skill deciding for any given piece of information which section owns it. Remember, subjective is what the patient reports. So the subjective is what the patient says. It's always good to put it in quotation marks. It's not your interpretation. It is subjective. It is what the patient says. Dietary changes, stress, caregiver load. Symptom descriptions, use those direct quotes. For example, patient states smoking helps her feel calm and she fears relapse. This is subjective because this came from the patient, right? Now, what about reporting a dietary change without symptom improvement? You reassess and adhere and behavior support tools at follow-up. So you have to ensure that the patient has done what they wanted, what you had repeated or ordered them to do. Objective data is what you see. So it's vital signs, BMI, the physical exam, and labs. Assessment. Don't document a lab under plan only and never omit a result because another provider obtained it. If you reviewed it and it informs your reasoning, it belongs in the note. Assessment is ranked clinical judgment. Improving blood pressure and BMI with persistent high dietary sodium means you reassess behavioral patterns and reinforce modifiable risk. Do not remove prediabetes diagnosis on the partial improvement. Don't abandon the focus area, and don't add non-compliance as a diagnosis ever, ever, ever. Documented bias risk is there every time you document. So it's tempting, but you need to stay objective when you are writing, and you cannot interject your opinion into anything. All right, so let's look at new knee pain, which is preventing walking. It's documented as a barrier, and the activity plan is adjusted around it. Removing activity recommendations entirely, ignoring the report until confirmed, or adding a diagnosis without changing the plan at all fail the patient. So when an option asks you to delete information, defer documentation, or blame the patient, wrong, wrong, wrong. It's never going to be the correct answer. Red flags. All right. This is a true skill, being able to identify red flags. And this is, you have to know when, for example, a health promotion visit escalates and carries a disproportionate clinical weight. The escalation findings, like sudden onset chest pressure radiating to the jaw during walking, every element is significant. Sudden onset pressure rather than sharp pain, radiation to the jaw, reproducibility with exertion, together describe a classic anginal pattern. So it's concerning for coronary ischemia. This exceeds the scope of a wellness follow-up and requires urgent cardiac evaluation, not lifestyle counseling. So this is not a health promotion visit. Things need to be changed. So red flags are defined by pattern and trajectory, just not severity, and of the patient's language. So ask about the onset, radiation, provocation, and whether the symptom is new. Those 4 questions separate escalation from counseling. Practical note for documentation: when a red flag surfaces during a wellness visit, the HPI captures the characteristics, the assessment names the concern, and the plan documents the escalation and the time frame. So I always will go back to old carts. I use it myself when I have a patient, especially a patient that presents, because I work in urgent care. When I have a patient that presents that has absolutely no business being in urgent care because they're an emergency patient, I have to be cautious. I need to document objectively. I cannot let my opinion be present in my documentation. I will write everything in the HPI. I will have explicit comments in there. I will also, on my plan, document everything. And you need to cover yourself. If the patient doesn't go to the emergency room, they need to sign out AMA, and that needs to be scanned into the chart so that they can't come back and say they didn't get appropriate care from us. Or call an ambulance. That's what I used to do when we worked at Advocate. If we had a patient that presented like that, we always called an ambulance. The patient had the right to refuse to go with the ambulance, and they would document that. The ambulance driver would document that. At the organization I work for now, it is a little more lax in that degree. We only call an ambulance if it is a true emergency. The patient is not able to, respond to us, or if they agree to it, we'll call an ambulance. An example of one of the cases that's in the exam itself. It doesn't give you the answer. I wouldn't never do that. But I want you to walk through the case and look to see where the principles belong that we've discussed, right? Okay, so here we have stages of change, and I really like this trans-theoretical model because I truly believe that this one is applicable. I'm kind of cynical when it comes to models. and theories and things like that. But I believe that there is definitely relevance to this one. And this one I use in my practice. Now, I work in urgent care, right? But a lot of people don't have a primary care provider, and we will act as one for them if they do not have one. It's not easy. You yourself may know. If you're ill and you're trying to get into your doctor, he has an appointment in 2 months. Well, I've got 103 fever today. I need to be seen. So they come to us. And that's fine. That's one of the things that we're there for. But they also may not have a primary care provider. So I'll do lots of general wellness and teaching and education to patients, and I incorporate this. I know that when a patient is not interested in changing, there is no point in wasting my time going over the steps to quitting smoking. It isn't going to work. It's a waste of my time. Contemplation, they're thinking about it. Okay, so I never judge patients, and I always tell them I never judge patients. I never judge them. The fact that you smoke, that's your thing. I used to smoke back in the day. So I think that sometimes when I use that type of attitude, they feel more comfortable, and then they'll say, I have been thinking about quitting. I want to quit by the time I'm 40 or something like that. Well, then we can say, well, what are your plans? Have you thought about that? And we can then introduce that into the conversation. Now, they may not be ready to take action and actively perform a new behavior. This slide in particular is talking about someone exercising. But I like to use stopping to smoking because it's really difficult too. But when they're ready, they'll actively perform that new behavior and they'll go through those steps. Maintenance is the tough one, sustaining that change and guarding against relapse, and knowing that if you do relapse, it's okay. A lot of people relapse. Research supports the fact that patients with substance abuse relapse a minimum of 3 times before they eventually are successful in their abstinence from the substance that they've been addicted to. Okay, motivational interviewing. Love this too. I also use this in my practice. Reflective listening, very good tool for exploring ambivalence. I will go into the room, especially if the medical assistant has warned me in advance that this patient has got issues. She's mad, she waited too long, blah, 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 lots of things. So I go in, I always greet my patients with a smile and a lot of energy and introduce myself and sit down, look at them, and I say, how can I help you today? I'll then leave it open to them. I sit and I listen. Listening is the best tool any healthcare provider has. You never learn anything with your mouth open. So sit and listen, and it means a lot. Many patients feel as though they've never been heard by a healthcare provider in the past. Use open-ended questions. Don't use yes or no. That is like reading off of a cue card, all right? So ask them and roll with any resistance. If someone doesn't want to get vaccines or they're fearful of vaccines, ask them why. And I've had patients come in and they go, you know what? We don't want our children to get vaccinated, and we need to get a letter stating that from a healthcare provider that is for religious reasons or whatever. We do that. But I also have to talk to the patient and document why they believe this way, and I don't do it. What worries you most about the vaccine? And have you always felt this way? I had a patient who she was not vaccine hesitant at all until her one child had developed a seizure following a vaccine and then ended up with a seizure disorder. Now, did the vaccine have anything to do with the seizure? We'll never really know. The child could have had a seizure disorder regardless, but that made her develop this vaccine hesitancy, and none of her children, she would not allow any of her children to get vaccinated. So let the patients voice their reasons and unsolicited advice. And this is the prescription instructions are not something that is related into motivational interviewing. So when you're taking a test, it's important that you read all of the answers completely. I can't tell you how many tests I took that I got wrong because I missed the word except, I missed the word always, because I thought I knew the answer right away after reading only half of the question. All right, so let's talk about the 5 A's framework. Assess, advise, agree, assist, arrange. Hold on, I'm looking at notes that I wrote. The confusion when looking at these 5 concepts is almost always between advise and assist. Advise is one directional. The clinician delivers a clear, personalized, evidence-based recommendation. And assist is collaborative. The clinician and patient build the action plan together, identifying barriers, skills, resources, and supports. So if in the question you're reading the words collaborative, plan, or together, the answer is always going to be assist because it's collaborative, right? Note the distractor ask, and that belongs to the 5A model for tobacco cessation, not to the behavior change version used here. Recognizing which variant of the framework the STEM is using prevents this mismatch. You want to assess the patient's current behavior, readiness to change, risk factors, and beliefs. Advise, give a clear, personalized, evidence-based recommendation. Agree, set collaborative goals. The patient genuinely endorses. Assist, that means you are going to co-create the action plan. Barriers, skills, resources, supports, problem solving are all discussed and worked out. Arrange, that is the schedule, follow-up, referrals, and ongoing accountability. So you're going to find that this is an important piece to the exam. All right, so barriers, adherence, and self-efficacy. Low burden, evidence-based strategy. This is in regard to habit stacking. So small activity goals into an existing routine. Habit stacking attaches a new behavior to an established cue. So it removes the need for new time and new willpower. The distractors escalated demand rather than lowering it. So 60 minutes a day immediately, strenuous morning workouts, and eliminating all sedentary behavior. Escalating the act of the patient who just failed. A modest goal predicts another failure. So you don't want to say, exercising 60 minutes a day in a strenuous morning workout or eliminating all sedentary time is an appropriate goal. You need to start out small. I always consider it a small test of change. So everybody, all humans, are more likely to accept a change if it is given in little pieces. And once they master the little piece, then you'll put it in a bigger piece. Once they master that bigger piece, add another piece until you have finally reached the goal that you had anticipated. It sets you up for failing. So we want to look at the real barriers setting the patient up, build achievable goals, progress tracking, social interaction, action, and perhaps integrate digital tools into our patient teaching, like a walking app, or if someone is on weight management, an app for diet and exercise. Lifestyle prescriptions. So not all prescriptions go to the pharmacy. Sometimes the prescription is going to be exercise. So if someone's obese and they have knee pain, we're going to do something that's very low impact, like swimming or cycling. No running, plyometrics, or rest. I generally will send these patients to physical therapy. Nutrition. DASH lowers hypertensive risk. Mediterranean reduces inflammation and improves lipids. So the first step of evaluating and coming up with a plan for nutrition is recall. Now, PCOS, that's polycystic ovarian syndrome. Typically, we're using this as a patient example. She has a BMI of 33, preventing T2DM, modest 5 to 10% weight loss, no fat elimination, no immediate keto, no vigorous exercise alone. The patient has obesity sequelae, so she snores, daytime fatigue, so she's probably got sleep apnea. The patient's breastfeeding, and she has mild depressive symptoms. She likes Tai Chi, so deprescribing can occur when lifestyle gains make the current medication dose a hypoglycemia risk. So we're talking about a patient that's obese with a risk of diabetes, and she has a little baby, so she probably was a gestational diabetic who had PCOS. PCOS is actually an issue with the thyroid. Stress, coping, and alcohol. We have the general adaptation syndrome, where we have alarm, resistance, exhaustion. An example of this is a caregiver with months of fatigue, insomnia, weight gain, and poor concentration. They're in the exhaustion stage. Maladaptive coping. Wine every night, skip meals, social isolation. Those are all maladaptive coping mechanisms. And heavy drinking after worsening depression signals deteriorating mental health, not resistance. Alcohol is a depressant. So when you're depressed, alcohol is not the way to go. You may feel as though it lifts your spirits initially, but that only lasts so long, and then bam, the depression takes over. Remove alcohol from the home if you can. Identify alcohol-free coping activities, switching beverages and drinking on an empty stomach, or substituting sugary drinks. They're all distractors. But it's difficult. Patients may say, this is the only thing I have that's keeping me sane. Well, we need to address what is causing the issues. Okay. Behavior change is going to alter, behavior change is enacted by altering the environment. Willpower alone's not enough. You've got to have a plan in place. Tobacco dependence. This is another example of one of our vignettes. Withdrawal from nicotine. They have a craving, urge. tolerance and needing more for the same effect. And she rejects cold turkey but is open to cutting back. And so I'll work with patients. That's okay. You want to cut back? Let's start reducing your cigarettes. How about you start out with smoking 1 pack a day for a week? And then we're going to go down to, eventually you'll get down to 1 pack for the whole week over a period of time, slowly reducing that. So you're lowering the level of nicotine in their system gradually, plus also teaching them other coping mechanisms while they are slowly eliminating that smoking. Burnout and moral distress, provider self-care. All providers, whether you are a home caregiver of your parents, nurses, big time. We don't take care of ourselves. We come to work when we're sick. We care for everybody but ourselves. And the hallmark of burnout includes emotional exhaustion, depersonalization, reduced sense of accomplishment. And one of our vignettes talks about Olivia's detachment and self-doubt. We really don't do a lot to help nurses in the workplace. We want you to come in and work extra shifts because we're short-staffed, right? And what is your reward? Your reward is maybe you'll get a bonus or overtime. Maybe you'll get a pizza. Big deal. Big whoop. It's not helpful. Early on in my career, I had been a nurse for about 13 years when I became the director of the unit. I had 160 staff, and we were busy. It was a busy OB unit, so I had labor and delivery, mother-baby, nursery, and special care nursery. I had 2 outpatient clinics and an education component. So I was busy. And the staff was very busy, and I could tell when they were getting burned out. So I would do things like, okay, we're going to have a raffle. Someone's getting a massage today because we had a masseuse that would come in and give like 15-minute massages for $10. I can't remember. It wasn't a lot of money, but we would have these raffles. I would try to do distractors for them to let them know that they were valued and that I appreciated them. If I saw that someone was acting irrational, out of sorts, I had to deal with that too. I had a patient who she was bipolar. I did not know this, had worked with her for years, but she had I don't know if she had stopped taking her meds or her meds just stopped working, but she had a huge issue. She actually ended up in inpatient for a while, but she came back. She sure did not like it when I approached her and to recognize what was going on with her, but after she became stabilized, she appreciated it. So that's kind of moral distress, the right action. Now I was able to do it, but what if you're a nurse and you know what should be done, you know the right action, but you can't do it because there's a policy that says you can't? Consequences. Decreased provider well-being raises the risk of medical errors. You're working. I never was a fan of 12-hour shifts. But I used to have young nurses who wanted to work 3 12s in a row, which I would not allow. You're not safe. I didn't like them working 2 12s in a row, but I would allow it. And they all did. Maybe because they're young and they get used to it or whatnot. But for me, I used to work 1 12-hour shift a week, and it would knock me out. It was real busy. And when I was a staff nurse, I would work in labor and delivery for 8 hours, and then I would do an NST clinic for 4 hours every Thursday. I was off on Friday. And I'll tell you, I had 3 young kids at the time, but I was useless on Friday. I wanted to sleep constantly. Barriers. If you have a unit that frames breaks as not being a team player, that's a toxic organizational culture. Now, something I can say about the organization that I work for now, I'm very impressed with. They just initiated this procedure or this policy. You have got, if you work a 12-hour shift, you are required to take 2 20-minute breaks. One at least less than 5 hours from the beginning of punching in, and then your second one needs to be no more than 5 hours after your first one. And human resources will call the clinics to make sure that we're taking our breaks. And we will get penalized if we don't take our breaks. And I said, well, what about the patients? Because the patients are still signing in. They said, don't worry about that. The patients will wait. And so I have advised our medical support staff to tell the patients that are signing in that our provider is taking a required break, and there will be a 20-minute wait delay extension to normal wait times. And it's been okay. And you know what? Taking that break, even though it's only 20 minutes, amazing. Love it. Practicing what you counsel. All right. So it's an app with insomnia and daily fast food. I can't remember what I meant when I wrote this. Let me look at my notes. I put this together so quickly. All right, here we go. So let's look at the advanced practice provider with insomnia. Eats fast food every day, 6 months without exercise. They're more likely to experience decreased confidence in counseling patients on those same behaviors. Does that make sense? I think it does. Credibility in health promotion is partly experiential. So how can you advise a patient to do something that you yourself should be doing and are not? Right? All right. Now, let's look at students. It is a great idea for students to perform self-care, like meditation, journaling, and exercise. This is going to guide them in the transition to your advanced practice role. You're going to have stress, absolutely, when you first start. It is a new world. You're going from being an expert nurse to a novice nurse practitioner. But you cannot forget self-care. If you forget self-care, it's going to make everything that much harder. Ethics, consent, and scope of practice. So we have informed consent, veracity, scope of practice, HIPAA, and guidelines. You should be always, you should be pretty knowledgeable on these topics now. All right, population health, equity, and advocacy. So this speaks to population health, determinants, and advocacy. 8 items makes this one of the most heavily weighted domains that you're going to see in the exam. So this is really a hot spot, okay? We want to see if we want to examine the physical environment of patients. Poor walkability, perhaps They don't have sidewalks, or the sidewalks are broken, or it's dangerous. Limited green space, mold, highway proximity, food deserts. Could that be the determinant behind the obesity, cardiovascular, and pediatric asthma patterns? Perhaps it is. Where's the nearest grocery? If it's 11 miles away, that is a big barrier. A health needs assessment. Now, I do this every year on patients when they come in to do their general wellness exams. I explicitly go over. My doctor does it with me too. There are a whole list of questions in our electronic medical record, and we only refer to them at times that we're doing a general wellness exam. And in that case, we are looking for social determinants of health, equity, advocacy, and the different nuances of population health. This slide speaks to the prevention across the lifespan. Infants and adolescents. The biggest cause of death is accident, pregnancy, middle adult, older adult. And the organizing principle here of all of these subsets is growth, development, and risk factors, and they shift across the lifespan. So wellness promotion is tailored to the developmental stage. I really, really, really like Erickson's stages of development, only because I have seen in practice that they are truly applicable. All right. So this is a little bit rapid recall. This is like a cheat sheet for you. Know these concepts, memorize these concepts. And again, when you're taking the exam, don't read too much into the question. One of the biggest causes of missed questions is number one, not reading the question completely, and number two, reading things into the question that are not there. Okay? So good luck to you, and I hope that this has been helpful for you.